Yeah, hi, Senator Gallagher. My question is for Professor Kelly, if that's okay.
Yep. Go.
Professor Kelly, given that there is such a low risk of children getting severely ill from COVID and dying from COVID, how can you justify the rollout for 5 to 11-year-olds, given that the trial data consisted of two groups of around 1,500 each? The second group, the FDA in this report hadn't yet finished reviewing, so I haven't been able to read its data. But given that 1,500 is such a small sample size, and that the actual trial only went for a short period of time, a couple of months, and then they only followed up for about 2.5 weeks after the second dose, don't you think we should wait before we even consider rolling out the children, given that there needs to be more evidence?
Thank you for the question, Senator. So, as I mentioned, and I may not have been quite as clear as I would, so just to make sure I've got the record correct, I did mention a number of 22,222 children in that age group who have contracted COVID. That's this year, from 1st of January to 21st of November 2021. You're quite right that of those, only a very small number, 1.4% in fact, have been hospitalised, and less than 0.05% have been in ICU, and we've had, unfortunately, a death in someone who had many other illnesses. So the severity is there's no doubt, and we've never said anything differently, that the severity is less in younger people compared with older people. But we've found over recent times, particularly in Victoria, and any parents on the call would know how disruptive it is when there are children when children in a classroom, for example, are infected. And this is not a trivial infection for many of those people. So it can affect school. It's already been very much disrupted for the last 2 years, particularly in those in the 3 jurisdictions that have had and continue to have outbreaks. We know that in many areas, and this is very well documented globally as well as here in Australia, that children do transmit the virus. So that's something that's come with later variants. Certainly Delta is like that, I suspect, and we already have evidence in Australia that Omicron will be like this as well, that children can transmit the virus effectively and efficiently. And just to take the example of the recent Omicron cases that started with a single person who was infected in a climbing gym in southwest Sydney. Within a week, it has got into 2 schools. Both of those schools are closed in Sydney. It's got into a school, Lynham School here in the ACT. There has been casual contact through the ACT to Gundaroo. So children are transmitters of this virus. The vaccine does, and we know can affect that transmission. It's not only about the protection from severe illness. In terms of the small sample size, you're quite correct. That was something we wanted to see more information than what was originally presented from the clinical trials in the US. That's one reason why we've been cautious and watching what's happening in the US. And I mentioned earlier, you may not have been on the call at that point, but myself and others from the department, the TGA and ATAGI met with colleagues from the US today to hear about their experience of over 5 million doses in that exact age group. So recognising we have about 2.3 million in that age group in Australia, that's a substantial sample size, who they've been following very closely and carefully for vaccine side effects and have not really found anything at all severe. And even those myocarditis cases that we are wanting to know about, there was only 4 in that over 5 million doses. So an extremely rare event. All of those were mild, short-lived and self-cured.
Okay, so in regards to the transmission, though, you have to admit that the vaccines haven't stopped transmission. We know that the Omicron variant came to Australia through vaccinated arrivals. So, and plenty of people, it's well known now that vaccinated people transmit the virus as well. And so I don't necessarily buy into that. And the other argument that children can't go to school, well, that's you're trying to put a pharmaceutical solution to a political problem. So I'm not really sure that's correct as well. But anyway, that's your opinion. I just want to touch on the severe pain/injury in the trial was 0.3% for the 1500 trial, first trial I think it was, and I think it was the same for the second trial off the top of my head. That's about a 1 in 300 event. I noticed Professor Skerritt said yesterday there was a 1 in 3,000 chance of a child getting some sort of as he described it, funny. I'm not quite sure what funny means in his terms, but condition from COVID. Given that you could have a serious injury or pain, there's a 1 in 300 chance of that versus a 1 in 3,000 chance, not taking into account infection rate. Don't you think that the cost-benefit analysis doesn't stack up?
So, Senator, just firstly on the transmission reduction, that's not my opinion, that's the science. Yeah. There's definitely a decrease in transmission from the virus, but I'll respect your difference of opinion on that, but it's not my opinion, that's what the studies have shown.
I'll accept that.
Senator Rennick, the way we run these hearings is that we allow the witnesses to answer the questions that have been put, and then you can respond again. We don't interject. It's just impossible to run the hearing any other way. Sorry, Professor Kelly, continue.
Thank you, Senator. So I couldn't quite hear what you were talking about in terms of adverse events, I think, in relation to the or so-called side effects in relation to the vaccine. I think Professor Skerritt is on the line and he may be able to elucidate. But again, from the discussion I mentioned from the US experience, 5 million doses, post-market surveillance, exactly what we've been doing right throughout the vaccine rollout and will continue to do, very close and very detailed information coming in and being analysed on a daily basis. They are seeing adverse events, but it's mostly exactly what you would expect from and what we've found from the adult vaccination rollout. Pain in the arm, sometimes the fatigue, body pains, occasionally mild fever. They were the key things that came through from the discussion today, and that's very similar to what we've seen elsewhere. There was just those 4 cases I said of that side effect that we know about, and we've seen in young adults and older teenagers, and we were very interested to hear about what they were finding in that group. But again, I would defer to the experts who are on this committee today, Chris Blythe in particular, in relation to that.
Senator Rennick, do you have further questions for Professor Kelly or General Fruin?
Look, I have a general one regarding the adult trial, and I've been reading through those papers, and in the initial Pfizer trials, basically they say they didn't test for pregnancy, breastfeeding, frail patients with comorbidity, patients with autoimmune or inflammatory disorders, interaction with other vaccines and long-term safety data. Given that there's only 22,000 in the initial cohort and then 22,000 placebo, and then they ended up vaccinating the placebo group as well, I wonder if you think that really was a big enough sample size, given that Professor Skerritt earlier said this year there was a 1 in a million chance of having an adverse event. I don't know how he could have, serious adverse event, how he could have come up with that number, given that the sample size is only about 44,000 people.
Okay. We might go to Professor Skerritt later. It is a little bit difficult to hear you, Senator Rennick. I don't know whether it's I'm struggling to follow the logic of the content of what you're saying or the volume of what you're saying, but what was the paper you referred to initially? You said you've been reading the papers. It might help witnesses if you're able to articulate what paper that is that they are being asked to respond to.
Yeah, so it was the initial Pfizer report that reported back on, the initial safety data from the trial, and then it's known. I'll read it out to you. And just
who the author is. Sorry, Senator Rennick, the author of that report. You said the initial Pfizer report. It's not clear to me what that is.
Yeah, so it's the EU RMP version .1.0 dated 21st December 2020.
Okay, thank you.
Senator, I think that those questions probably are best addressed to Atagi. I think Senator Rennick's talking about the early trials, which have certainly been superseded by the hundreds of millions of doses of real-world experience and safety data we have now. So, I mean, for example, in the AstraZeneca trial, the TTS condition wasn't picked up at all. And I think Senator Rennick is right that some of those early trials were relatively small numbers, but we in Australia have been in a position of not starting our program until the rest of the world had delivered tens and hundreds of millions of doses, and that is a much more realistic readout on the safety of these vaccines. As Professor Kelly said, in the US, 5 million children with 4 cases of pericarditis. That is a much better real-world safety readout than any of those initial trials. But the ATAGI co-chairs have considered all of these issues and would be happy to address the issues of pregnancy, immunocompromised people, but we now have such good real-world safety data, we're much more confident than we might have been just reading those initial trials. So we could put them to ATAGI's chair if
in the second.
Senator...
I'd just like to touch on a couple of questions. First of all, Professor Murphy, and then I'll go to ATAGI. I noticed that Professor Murphy said almost everyone will certainly get COVID. I'm curious as to the basis of that, because in the UK, 10.5 million people have got COVID out of 66 million, so about a 1 in 6 infection rate over almost 2 years. And in Sweden, 1.2 million people have got COVID out of about a 10.5 million people over almost 2 years as well. And both those countries have much longer winters, larger populations, much denser populations. Why do you think that everyone will get COVID in Australia, given that most other countries have an infection rate of between 1 in 6 and 1 in 10 over, 21 months of data?
Well, thanks for the question, Senator. So over that period of time, there were lots of public health and social measures in place in those countries that varied from time to time. There were lockdowns and masks and various measures and when I was saying most people will eventually be exposed to COVID, I'm talking over a period of some years, perhaps. Pretty much every Australian adult has been exposed to influenza. These viruses eventually will circulate and progress around a country, and I suspect that most people around the world will be exposed to COVID as it becomes endemic. So obviously there may be some people who have, from other coronavirus infections, that they might have had some immunity and some protection. We don't know for sure, but I think it's pretty likely that most people will be exposed to it and the great majority will be infected. I don't know whether Professor Blythe is more of an expert than I. He might want to add something to that.
No, I think the timeline is uncertain at this stage, but I do agree, given what we've seen internationally and locally at this stage, that we will all be exposed at one point. And importantly, some of the public health measures that are in place at the moment are likely to adjust the rate at which that occurs.
Yeah, okay, I accept that. I should note, however, that Sweden has stayed open nearly the entire time. They had one brief lockdown, but they stayed open most of the time, and they've got a lower infection rate than the UK, which had a large amount of lockdowns. But I'll leave it at that. And just one other question, Professor Murphy, I just want to pick you up on that December statement, that December data. In your July TGA data as well, those gaps in testing were pretty much the same in regards to there had been no testing on frail patients, autoimmune patients, etc. So I'm happy to send you through the document that says that if you want proof of that. But just jumping over to ATAGI, is there any plans for ATAGI to further expand the temporary exemption guidelines? And in particular, I'm thinking about pregnant women. I noticed that you didn't extend the exemption for pregnant women, and I've been contacted by many pregnant women who want to wait to give birth before they take the vaccine, and some of these women are now going to lose their jobs up here in Queensland because, they want to, not sort of give anything to the baby, possibly give anything through to the baby. Is there any chance that ATAGI will further expand those temporary exemptions?
I think it's important, and thank you for the question, I think it's important to highlight that actually pregnant women are particularly susceptible to COVID, both themselves and also their baby. We know that pregnant women have a much greater risk of hospitalisation, intensive care admission, and also their baby has a much greater risk of being born early. And so that is why actually ATAGI recommends vaccination in COVID, in pregnancy, to protect the woman and the baby. So we don't believe, given that actually there is a demonstrated benefit, that there is a need for an exemption, but there's no intention to adjust that at this stage.
Right, okay. I just also want to highlight, I noticed that the FDA has given Pfizer 55 years to release all their data from the trials, from the initial trials. Are you concerned that Pfizer wants to withhold data from the trials and has redacted a lot of data, trial data, in the initial release of that data? Does that not concern you at all?
It's probably a better question for Professor Skerritt from a TGA.
Yeah. Yes.
Okay, sure.
Professor Skerritt, do you want to jump in on that one?
Thank you, Chair. So the FDA has been through all of Pfizer's original clinical trial data patient by patient in detail. What we do is look at the aggregated summaries, but we do, as a group of international regulators, of which Australia is vice chair and of which FDA is part of the executive, we've probably had, look, I don't know if it's 30 or 40 meetings discussing COVID vaccines, I've lost count, and we had a number of meetings discussing the Pfizer vaccine, both prior to its release on the market and indeed as recently as this morning together with the Centre of Disease Control, we talked about some of the safety data. So we're very closely joined up. There is data that is redacted that is of commercial value relating to the manufacturer. There was some early information, I think the Senator might be referring to, from some early data in August 2020. Of course, the approvals of a vaccine were based on analyses of data that came through later, and so we're not concerned.
Okay, well then, I noticed that in this latest release of data, the first 500 pages, Pfizer has conceded that there is a large increase in the type of adverse event reactions to the vaccines. Now, I know we've had this conversation before where you've said that basically there's a limited number of recognised side effects. Given with the latest release of this data, will you expand the number of recognised side effects as a result of the vaccines and therefore allow doctors to, say injuries are related to the vaccine, number one, and then also expand the indemnity scheme, allowing people to claim for other injuries?
So, Senator, our role is merely, as you say, the recognised side effects. And at the risk of sounding trite, we'll recognise a side effect as caused by the vaccine if the evidence, on the advice of an expert panel of specialists in that area, and again in consultation with international regulators, shows that there's a cause and effect relationship. If there's not a cause and effect relationship, then it's not a side effect due to the vaccine.
So what's your onus of proof on that?
It's a rather detailed onus of proof. Firstly, you've got to show that in time it was related to the adverse event. Secondly, you've got to show that there's no other plausible mechanism. Thirdly, identify how it could be medically related. For example, a broken bone had nothing to do with having a vaccination. It would be hard to show that bone spontaneous breakage was, just to use a hypothetical, was plausible. Then we also look at background rates, and remember that many things, including myocarditis, have a very significant, quite high background rate in the community. There's a number of other measures, observed versus expected. We slice it by the population. We look at the background rates, not just in the whole community, but also in the particular age group and gender and even racial cohort to get together with our colleagues overseas. So it's a detailed analysis, but we don't just do it ourselves. So if it's a neurological side effect, we bring in some of Australia's top neurologists. If it's a haematological side effect, as we did for TTS, we bring in some of Australia's top haematologists and so on.
Okay, I'll just be more specific with that onus of proof. Are you going to look, go on the balance of probabilities, like in a civil case, or are you going to go beyond the reasonable doubt, and these people have to prove beyond reasonable doubt versus balance of probability?
So the scheme which you're talking about, and our role is the medical assessment of information provided by relevant specialists and the treating doctor, is on the balance of probability there's no other likely cause for that effect. It is different from the broader TGA adverse event scheme. So it is a balance. It is a balance of probabilities scheme, and that information will, if it isn't already, shortly be made available in detail so that the detailed claims can be prepared.
Okay, and I note that the Sydney Morning Herald about a month ago said that there were already 10,000 claims for that indemnity scheme. How on earth, if you're going to have to do a detailed assessment of every one, how quickly do you think that you will get through all those, claims? And, my understanding is more and more people are claiming all the time, so it could end up, there's been up to 80,000 recorded cases for the CGA, of which I imagine.
Okay.
Can
I just jump in there? Can I just jump in and say, if someone's not on mute, could they mute? There's a lot of background noise. Professor Skerritt, you don't have the best line, so there is.
Sorry,
I don't know what's going on there, but it is quite difficult to follow some of what's going on. Professor Murphy, did you have something you wanted to say?
So Ms Shakespeare is the relevant official who can talk about the indemnity claims, and I think she might be best placed to respond to this issue about the intention to lodge and the claim scheme.
Okay, I'll hand to Ms Shakespeare if she's online. I can't see her.
I'm here.
Okay, you are here. We can't see you, but we can hear you.
Penny Shakespeare, Deputy Secretary, Health Resourcing. I'm not sure why my camera's not working.
No, we can see you now, Ms Shakespeare.
Great. So we haven't actually received claims through the Services Australia portal for the vaccination claims scheme because it hasn't opened. It will open officially next week. We've been contacting directly some of the families of people who were deceased and are talking them through a fast-tracked application process. So I think that the number that you referred to, Senator Rennick, were the people that had registered their interest in the scheme. We're contacting them all at the moment by email to provide them with more information about how they can make claims, about information for the types of injuries that will be covered by the scheme and the sorts of documentation they would need to get together to put in a claim. So I don't think it's the case that we'll have that many claims actually submitted. Those were registrations for people who are interested in the scheme, and we know that we at least had a couple of thousand of duplicate registrations there, so those numbers are probably a bit overstated.
Right, okay. I just want to come back to ATAGI and the exemption for pregnant women and tie that back into the trial data from Pfizer where they said that they hadn't tested on pregnant women. Now, I know there's been one subsequent test on pregnant women that went for about 2 months and tested mainly women in the third trimester. However, that trial didn't then go on and continue to monitor the baby's health after the baby was born. Why isn't ATAGI taking into account the lack of detailed trial data on pregnant women, in assessing the risks and rewards of the vaccine?
Thank you for the question. I think ATAGI has taken into account the lack of trial data, and that is why ATAGI, in the early rollout, particularly with low COVID numbers in Australia, did not strongly recommend pregnant women get vaccinated in the first part of the rollout. However, once we had emerging data from large studies from Northern Hemisphere demonstrating, one, the safety, but also the risk to pregnant women and babies of getting COVID, we adjusted our recommendation at that stage. There remains limited trial data, but importantly, there's a wealth of real-world data demonstrating not only of benefit to pregnant women and babies, but also the safety of that approach, and that's why we strongly recommend. Some of these data particularly highlight that actually the rate of adverse events in pregnant women of vaccinees versus non-vaccinees are not significantly different. And so based on these data and the potential benefit is why we would strongly recommend pregnant women be vaccinated during pregnancy to protect themselves and their baby.
Okay, well, can you send me those trial studies through, please? Can you take that on notice? Because I'm only aware of one trial and it was quite short and had limited numbers. So I'd be curious, I'm keen to see what data it is that you're relying on. Anyway, look, I'll leave it at that.
Professor Blythe, sorry, Senator Rennick, Professor Blythe, is that something you're able to do to provide to the committee?
Sure.
If it's not
Would come via the department, Senator.
Of course,
so the question should be addressed to us. Yeah.
Well,
Sure.
I presumed that's where it would go. So, okay, if it's not too onerous, that would be useful. Maybe we could
No, it's
convince.
not, Senator. We
Maybe
already
we
have
could
that
convince Senator Rennick that the vaccination program is safe. Maybe.
Well,
Professor
Senator Gallagher,
Skerritt.
talk to the people that talk to me, but anyway, go on.
Yeah. Professor Skerritt.
So I was just saying we already have assembled that information. There's about 5 studies now on pregnancy showing no difference in pregnancy outcomes. Sadly, as we know, quite a significant number of pregnancies, even in apparently healthy mothers, do end in miscarriage, and it's extremely sad for families of those involved. But the key thing is those studies have shown there is not a difference between the vaccinated group and indeed the unvaccinated group in terms of pregnancy outcomes. But through the department, as Secretary Murphy said, we're happy to share those studies.
Thank you.
Thank you.
Senator Rennick, do you have further questions?
Look, I mean, I'm sort of repeating myself,
Yeah.
but I'll ask Atagi this question from a question I asked earlier on. Are you satisfied that there's been enough trial data with the children, given that there's very low risk of children getting ill from COVID and subsequently dying? Are you satisfied that the trial data is big enough, given that 1,500 is quite a small sample size when it's going to be rolled out to millions?
Thank you for your question, Senator Rennick. As I said previously, 1,500 is a relatively small number, but actually that's to demonstrate that the vaccine works and gives a description of the safety profile. To picking up on your question about before, I'd refer you to the study protocol, which outlines what the definitions of severe side effects are. I think that would be very useful for you also. But importantly, that is why we've actually gone to international bodies that have been collecting these data. As more than nearly 5 million US children have been vaccinated, we have been looking very closely to this data to find out what they're really seeing to give us greater confidence compared to the trial data. Importantly, both of those factors have influenced our decision and will influence our advice that's forthcoming.
So do you think that's ethical to be treating children as experiments, if you're effectively saying, well, we're going to just roll it out and then use the children as an experiment rather than actually conduct longer trials, which normally take up to 7 to 10 years for drugs? This trial went for two months, the Pfizer trial, and only looked at adverse events for up to 17 days median duration. Is that really satisfactory?
As a paediatrician, I don't think I agree with your position there that we're experimenting on children.
No.
What we do when we assess a vaccine is we look at the benefits and the risks. Now, I appreciate that this age group, actually, the risks of severe COVID are clearly lower than other populations, and so that's why we've actually taken a cautious approach, taken our time to assess that. But actually, that is not an experiment. That is basically using data to inform rollout of a program. We do not have the capacity to wait for 7 years waiting for data to emerge in the setting of a pandemic. If there's an active problem at the moment, we need to use the best data we have at this stage from clinical trials, from real-world evidence to inform our policy settings.
Thank you.
Senator, could I...
Thank you, Professor Blythe. I will go to... Sorry, Senator Rennick. I will go to Professor Skerritt, I think, in light of the allegations that you've just made in the committee, and I would like to say that the committee does not believe that there are experiments being conducted on children. Professor Skerritt.
Thank you, Chair, for your indulgence. I just wanted to correct one thing and comment on another.
Just
clinical
one thing.
trial.
Just one thing.
Yes. Well, the phase 3 part of a clinical trial of a medicine or a vaccine, does not take 7 to 10 years. It is a group of people assembled for a period of a couple of months where they look to see whether the vaccine is causing an antibody response and whether it is preventing against infection. And so the actual duration of this trial is not all that different from the normal duration of the trials. Clinical trials do not take 7 to 10 years. With respect, I think the Senator is confusing it with the normal chemical drug development pathway from the very first time a chemist synthesised a molecule through to the drug being available in man. So it's important to emphasise that clinical trials do not take 7 to 10 years, Chair.
Thank you very much, Professor Skerritt. I think that is very important.
Please?
Senator Rennick, can you just hang on a second? I think that is an important clarification. Senator Rennick, do you have further questions?
So you're saying that it's typical for a trial to last 2.5 months, number one, and for a trial with the Pfizer one, it's mRNA technology. It's new technology. It's never been rolled out as a vaccine before. Are you saying that 2.5 months isn't the standard time frame because, or is the standard time frame? Because I've followed drug production in another life quite a lot, and these things take years. I mean, I've had had a stock that's still going on 5 years later with its drug trials, and that's for a cancer stock, a cancer drug, where the risk of cancer is much higher. And finally, I don't think we've got a pandemic of COVID amongst the children. I think that's alarmist language to use the word pandemic, given the low death rate and fatality rate and hospitalisation rate amongst the children.
Okay. Okay.
Thank
There's
you.
a lot there, Professor Skerritt, to unpack. If you could work through those, I think it is important. Thank you.
Okay, we'll work through them then, Chair. Firstly, we've had 22,000 cases of COVID in the 5 to 11 in Australia, and by any measure, that's a significant number of cases. As I've said before, we shouldn't just use deaths as a measure. The limitations on those children being able to go to school, the fact that especially in unvaccinated families, there's infection of parents and grandparents, the effects on mental well-being of children who have been infected and therefore have had to stay home and be isolated. And of course, the 1 in 3,000, 1 in 3,200 chance, which when there are 22,000 kids, that actually is quite a few kids who develop this multi-system inflammatory syndrome, which the US Centers for Disease Control has shown to be quite serious and lasting for many months. It's different from long COVID. So I reject the assertion that COVID is nothing much for kids and it doesn't matter if they catch it. Going back to clinical trials, how the children were done is the same way the children's flu vaccine and other children's vaccines that have started life as adult vaccines and then modified for children's were done. It's what's known as an expansion population. So the detailed clinical trials going through all the phases were done in adults, and then they're done in adolescents, teenagers, and then finally as an expansion population in children. And the main measure was to show that their immune responses were the same as the adults and the adolescents, and that there weren't serious safety issues from those populations. And that is why that trial could be done in 2.5 months. Now, again, as Professor Blight said, we're monitoring the rollout in those children, and the fact that the US is almost a month ahead of Australia and actually will be 6 weeks ahead of Australia does give the opportunity, although I reject the term guinea pigs, to reflect on their experience. And after over 5 million vaccinations in the US, we've heard from CDC and FDA colleagues that the number of serious side effects are extremely low in children.
Professor Skerritt, thank you for that. Professor Rennick, I feel like I've indulged you enough with this line of questioning. Do you have another question?
Yeah, last one, thank you.
Okay.
So have we done and anyone can answer this, have we done studies on the impact on children or adults of multiple booster shots every 3 to 6 months?
No, because at the moment there's no one having booster shots of a vaccine every 3 or 6 months. People would be up to their 7th or 8th shot, and that isn't done in every country. When there are booster shots, and there was a major study released in the top flight medical literature just last Friday, looking at booster shots of all the major vaccines on top of, so it was a combination. So it was booster shots times all the different first shots. And there was a very thorough study of adverse events and vaccine efficacy. That was the most thorough study, but there's been about 8 or 9 in the literature on booster shots. But because no one has given 7 or 8 booster shots of this vaccine, those studies have not been done. And we hope that we won't have to have 7 or 8 booster shots. But if it does turn out we've got to do these studies annually, there will be detailed safety follow-up.
Thank you.
May I, Senator Gallagher?
Yes, sure, Professor Blythe. Yeah.
Importantly, we have looked to the international data about the safety of booster shots, and there's a wealth of data coming from countries that are a number of months ahead of us in that space, looking at the rate of adverse events in myocarditis and are seeing very reassuring data. Importantly, all of those studies are in adults. There is not a program at the moment that's running, a booster program in children at this stage, and clearly Australia has not made the decision about going to a booster program in children without a review of these data.
Okay.
Authorised G. Rennick, LNP Chermside.